Hello again, it's Dr. Wood, and we're looking at some common data comparisons. So some different tests you're going to see being done fairly commonly in some of the research you're going to be looking up, what they mean, how we use them, etc. Starting off, we're looking at tests for normal distributions. Again, this is helping to tell us whether we're dealing with a normally distributed set of data or not. You may not see these done super commonly. However, you're going to see that if you need to test to see if you have a normally distributed set of data, this is what you're going to use, right? So either test for normality, you may find there's outlier tests are being performed, and really it's just looking to see how does your data set compare to the general population. Is it significantly different? If it is, then you would violate the assumption that you have a normally distributed set of data, and you would say, okay, well, it's not normally distributed, it's not Gaussian, and so instead you'd have to use, instead of parametric tests, you'd then have to use non-parametric tests there. Okay, so generally, if you want to have to show a sample set is normally distributed, you actually want a high p-value to show that your group is not that statistically significantly different than the general population. Next, you're going to have what we call more of our descriptive statistics, and you can kind of do this on almost anything in a lot of cases. Refer back to your the variables video a few videos ago, and you'll see kind of that chart that shows how you can use different types of variables with some of these descriptive statistics. But essentially, these can be applied to almost anything. So in terms of like frequency distributions, this is really good just to say, counting up like, okay, well, this many people said yes, this many people said no, this many people had a heart attack, etc. Right? So very, very basic. The mean, as we mentioned, is just being the average of all the values added up together. Again, you're going to find this more commonly applied to both normally distributed data and non-normally distributed data. Typically, medians are more so applied to either like ordinal variables, things that have an order to them, but not necessarily a degree of magnitude of consistent difference amongst the different categories. But you're going to see that median being used more frequently with non-normally distributed sets of data, non-parametric tests. Mode, as I mentioned, is just the most common value that pops up. Min and maximum value are going to make up the range of the data, so which is sometimes useful to describe kind of what was the highest and the lowest values that you ran into. And if you remember, we have the 25th and 75th percentiles, which are sometimes used in conjunction with the median, which the median is just the 50th percentile in order to describe sort of the spread of the data there. And then what you would apply to the mean instead of, say, the 25th and 75th percentile would be a standard deviation, right? So again, it kind of tells you that variation around the mean to see how spread out the data tends to be, or if it's very centered around the mean or more spread out. Now, let's say I was trying to make an inference about one population. I want to actually make a comparison to say, okay, well, I have this data set, and I want to see how their blood pressure, for instance, can measure up next to the general population's blood pressure. Say, we're giving them an antihypertensive or something like that. Here, again, when you run that test, it's a one-sample t-test, and you're going to be running your data set, your experimental group against kind of a general population sort of group there. And so if you see that you have a p-value less than 0.05, that means that your group is statistically significantly different than that population. There is a true difference there, right? Or there's less than a 5% chance that this is just due to random chance, right? And so again, that would be considered statistically significant. Now, again, an example of this, if I was, say, to look at cancer rates, they were to take a sample of Hispanic men and then compare that back to men in general, that would be something where a one-sample t-test could be used, okay? That's going to be different than if I were to, say, compare a group of Hispanic men versus a group of, say, Caucasian men. You'll see that that's going to be a different test here. And so if I was comparing two groups together, this is where your paired and unpaired t-tests come into play. Remember, most of the time you're going to be running unpaired t-tests, meaning that the two groups have no relationship to one another. Now, say for instance I was using the same people pre and post a certain intervention, or if I was using siblings or twins or something like that, that's where the values are paired, and because they're related to one another essentially. And so in those cases, a paired t-test would be appropriate. Most of the time you're going to see unpaired t-tests being used there because the groups will have no relationship to one another. And again, a p-value less than 0.05 generally means that one group is going to be statistically significantly different than the other one, right? Now, just because your p-value is low doesn't mean that that expresses anything about the actual difference between the groups. It just means that there is a difference there, okay? So as an example, if I were to say give two groups, one is given placebo, the other one is given a new beta blocker, and then I look to compare the rates of myocardial ischemia. in that case, I would use an unpaired t-test in order to see which group had fewer cases of myocardial ischemia, right? If the p-value is less than 0.05, then I would be saying, okay, well, the beta blocker group had a statistically significant reduction in the number of heart attacks versus the placebo group, right? That'd be an unpaired t-test. If I was comparing more than two groups, that's where you run into ANOVA, or the analysis of variance. Again, this can either be paired or unpaired. So if you're doing a one-way ANOVA, this is analogous to using an unpaired t-test, versus a repeated measures ANOVA is going to be analogous to a paired t-test. Now remember, I can compare two or more groups together, and a p-value here of less than 0.05 just means that at least one of the groups is statistically significantly different than one of the others. It doesn't tell me which one, it doesn't tell me how big of a difference, it just means that there is a difference there. What you then do with that data is then you would go and do follow-up multiple comparisons to see what groups did the differences there. So normally you start off with, say, a one-way ANOVA, say with 3 different groups. You say, okay, well, the p-value is less than 0.05, there is a difference here, and then you follow up with, say, unpaired t-tests between each of the different groups to see which one actually had a statistically significant difference. Now remember, the multiple comparisons trap. If you keep running the same comparisons over and over again, you're eventually going to find something that's significant. So in those cases there, you have to take that into account. Otherwise, you're more likely to make a type 1 error, or a false positive error. Okay. So as an example, if I were to run an ANOVA, I could do something like comparing the average blood pressure of PA, nurse practitioner, and med school students, compare them all during finals week to see if there's a difference in that group there, right? So if I got something that was less than 0.05, then I would have to do pairwise comparisons, and I have to compare PA to nurse practitioner, PA to med school student, nurse practitioner to med school student, in order to find where the actual differences lie in terms of blood pressure during finals week. Okay. So those are all examples of parametric tests when I'm working with a normally distributed set of data. To compare that, we then have a set of non-parametric tests. And again, I always have to look these up because they're usually named after the statisticians that came up with them, and I get them confused all the time. So again, a quick Google search will tell you this, but just to show you the comparison, if you see someone using a Wilcoxon rank sum test, that is the non-parametric version of a one sample t-test. Okay. More frequently, what you're going to find is they use a Mann-Whitney and sometimes a Mann-Whitney U test. That is analogous to an unpaired t-test. That's probably the most common non-parametric comparison you're going to see between two individual groups. Okay. If I were to need something that was similar to a paired t-test in a non-parametric version, that would be the Wilcoxon's match pairs test. Again, it gets confusing because now I've got two tests named after Wilcoxon. Gets a little bit confusing there, but especially if you don't do biostats all the time. And then finally, the non-parametric version of the ANOVA, or the analysis of variance, and again, that's where I'm comparing more than usually two or more groups together, would be the Kruskal-Wallis test. Okay, so it's important when you read one of these to see, well, are they even using it appropriately? You know, if they're using a Mann-Whitney U test and they're trying to compare 3 groups together, that doesn't make sense, right? Because it's really only designed to compare 2 groups together, versus Kruskal-Wallis could do 2 or more. Okay, so big differences between those, and you want to make sure people are using them appropriately. Other ones you may see commonly include the chi-square test. This is really good for nominal or ordinal variables, most commonly for nominal variables. And basically it's just a frequency distribution, and what you're trying to do is to compare the frequency distribution as it stands versus what a theoretical one would be just based off random chance. And so by looking to see if there's an actual difference there, and again, you get a p-value, if it's less than 0.05, that means that there is a statistically significantly different difference there between what you would expect just on chance alone, and you expect, okay, well, maybe there's a correlation here, right? So as an example, if I was comparing men and women, right, so again, a binary dichotomy that I set up there, so men versus women, and I compared eye color, brown, blue, green, to see, okay, is there a correlation between gender and eye color? There probably isn't, but just as an example, if I were to compare these, I would get a theoretical distribution that would occur just by chance alone. I would compare the two together, my actual versus theoretical. If I get a p-value less than 0.05, that means that yes, there's a difference here. There appears to be a correlation between gender and eye color. Okay. Now, if you ever see a Fisher's exact test, that is going to be a case where if you typically have a small sample size, so say less than 30 participants, you'd use a Fisher's exact test. Again, it uses a little bit more conservative math in order to make it sure that you are less likely to make a type 1 error. Something you may also see, especially with like head-to-head trials of different types of, say, cancer treatments or, say, cardiovascular treatments and things like that, includes survival curves. This is basically where you're going to be comparing two groups to see how long people survive for. And again, what you're going to find here is that we frequently do not use average survival time because in order to get the average, you'd have to actually wait until everyone dies. Instead, what we can use is the median survival time. Basically, at what point do we hit the 50% mark, right? So in this case here, say we have our control versus our treated patient group, you can see here that it looks like the controlled group is actually doing better in terms of survival versus the treated group here. But again, this would be the median survival time, the point you hit where you have 50% of the patients still alive, right? So here would be 50 days. For the blue group, it'd probably be something later on, maybe 200, 300 days or something like that. Okay, so again, if you see that, that's basically what they're doing is comparing survival time between two groups to see if there's any inherent benefit to one strategy versus another. All right, so the last thing I want to talk about is going to be odds ratios, relative risk, and risk reduction, because these are also very common comparisons you're going to be seeing. So if I give a patient one type of drug versus another, you may find that odds ratios or relative risk is used to see, are they less likely to have an event occur? Are they more likely to have a side effect? All kinds of things you can show using these. Now, an odds ratio is basically what you're trying to say is that what's the odds of something happening in one group versus another, whether it be cancer, heart attack, whatever. Typically, you're going to use this in retrospective studies. You frequently see this, especially with case control studies. And that's because very frequently we don't know what the full population is that is at risk for an outcome happening. So in this case here, we're just using the odds, which is just using the people that we're including in our study here. Typically what you do is you'll have your numerator to get the odds of something happening is going to be the number of people with the outcome in question. The denominator is going to be the people without the outcome. You just divide those out. So as an example, if you were doing a case control study and I looked at 10 patients with lung cancer and I looked backwards to see what kind of risk factors they had and I found that 7 of them were smokers, you can say the odds of being patients with lung cancer being a smoker would be 7 to 3, right? Those are the odds of them being a smoker in that case there. Well, if I want to compare, say, the odds between, say, smoker or say people with lung cancer versus those without lung cancer, then I can get an odds ratio where basically I'm going to divide one by the other to see if the odds of someone with lung cancer being a smoker is higher than the odds of someone without lung cancer being a smoker, right? And so in this case here, it's important to remember that your null value, or the value that will denote significance, is going to be 1 because I'm dividing one thing by another, and if there's no difference between the two, they're obviously the same value. In this case here, 7 to 3 and 7 to 3, that value is going to be 1. Okay, that means if you have a confidence interval that gets expressed and it includes 1, it's a non-significant result. So as an example here, an odds ratio of 1.4 with a 95% confidence interval of 0.97 to 1.54 is not significant. In a lot of medical studies, you're going to find they will not show you the p-value. They will show you the confidence interval, and so it's your job to see, okay, well, it's an odds ratio. I know that if it encompasses 1, it's not significant. An odds ratio of 0.74 with a confidence interval of, say, 0.68 to 0.85, even though it's less than 1, it does not include 1. This makes it significant, right? Anytime you're doing a ratio of dividing one thing by another, if it includes 1, it's going to not be significant. Now, relative risk is something that usually gets used for prospective studies where you're going to be taking groups and actually assigning them to one group or another, say like a cohort study or a randomized controlled trial. Because I know the full number of patients who are at risk for an outcome, I can determine what that risk is, right? And basically, it just is going to be the number of people with an outcome divided by the total number of people at risk for that outcome in the study. As an example, say I followed 100 smokers for 5 years, and I found that 17 of them developed lung cancer. I would say my risk is 17 out of 100 people, and that would be 17%, right? This is different than the odds, which is the people that developed the outcome versus those that didn't. In this case here, if I was doing the odds of developing lung cancer, I would say 17 out of, and I guess 83, if my math serves me, 17 to 83. So again, you can see here the numbers might be similar, but they're going to be off a little bit. But since I know the full population at risk, which is 100 people, I can say here the risk for smokers developing lung cancer over this time period is 17%. Now, relative risk is very similar to odds ratio because you're dividing one risk by another risk. And so here again, the null value is 1. So if I have a 95% confidence interval containing 1 for relative risk, it is not significant. Okay. Another important thing to look at, though, is risk reduction, right? So you're actually subtracting one risk from another to see what the difference is there, right? So I can see, well, if I give a beta blocker to a patient with a heart attack, what is their risk of having another heart attack versus those I did not give a beta blocker to, okay? This is also really important because using risk reductions helps us to determine the number needed to treat or the number needed to harm in these studies, right? And so again, because one is subtracted from another, if there's no difference between the two, then that difference would be 0. So here, if you have a 95% confidence interval and it includes 0, then it would not be significant. So as an example, say I gave someone a beta blocker after a heart attack, and I compare that to someone I did not give a beta blocker to, and I found that there was a absolute risk reduction of 22.8%. If that 95% confidence interval ranged from 15.2 to 29.8, because it does not include 0, I would consider that significant. Okay, so differences there between a risk reduction versus, say, a risk ratio or a relative risk or an odds ratio. So those are common comparisons you run into in research. If you have any questions, please let me know, and I'll talk to you next time. Thanks a lot. Bye.